Um, I got to India, but I never got to Mumbai.
Oh,
And our discussants today, you know many of them, but Anne Marie, say hello, Anne Marie. You have to unmute yourself.
Sorry, I was trying to click to unmute and I accidentally minimized. So, hi everyone, I'm Anne Marie. I just finished up residency at UNC and now am a hospitalist at the end of my shift today. So excited to be on. A little brain dead, but we'll work through it.
Great, Kiki.
Hi, Kiki Tider here. Entering to my second year as faculty. I do both hospitalist as well as gen med, and excited to be here. Thanks for having me.
And Alonzo, who I've been making fun of for the last half hour.
Hi, everyone. My name is Alonzo Hudebert. I am junior faculty here at UAB. Dr. Centaur asked me to help create the cases today. With Dr. Centaur's blessing and idea, I got to conscript Mohit, who's going to introduce himself in a minute. But I did my training at WashU, where I was a chief resident, and then came here to UAB, where luckily thus far, Dr. Centaur has not thrown me out.
And Mohit, a lot of people know you. A lot of people follow you on Twitter, and they don't know that Alonzo was once your upper level.
Yeah, so I had the great experience of having Alonzo as my chief resident when I was an intern. And I'm now a PGY3 at WashU and will be a chief resident next year, filling his shoes as half at Barnes and then half at the VA. So
Great.
Just kind of follow in Alonzo's footsteps.
So they've prepared 3 scenarios for us to discuss. So why don't y'all present a scenario, and then we'll let our 2 Cracker Jack interns figure out what they would do, and then we have our experts who will tell us and expand.
Sure. Alonzo, do you want me to start with mine?
Go for it, Mohit.
Okay. So first case is about Miss Payne. She's a 70-year-old lady. She has a past medical history of hypertension and COPD, for which she's on 2 liters of oxygen at baseline. She has metastatic lung adenocarcinoma, is admitted to medicine for intractable pain secondary to spinal mets. She's been escalated on opioids during the past few days. Finally, pain management team has been following along, and she's recently been placed on a Dilaudid PCA. Her pain is greatly improved throughout the day. Overnight, while you're on night float, the nurse calls you that Miss Payne is just not quite herself, and her speech is starting to get slurred. I'll leave it there.
Okay, who is? Yes, Anne Marie. Ms. Payne, the name is a sign. Okay, let's see. If you're on night float now, you can answer this question, Sandkelp.
Should I start with should I proceed with the next steps or
Yeah, so just say how you would you get the call. What are you going to do? What are you thinking?
Given the scenario and her receiving a dilaudid PCA with a history of COPD, I would of course I'll first like to physically examine her, but I'm immediately thinking about hypoventilation from opioid-induced and also with a history of COPD. So I'll first go examine her and see what her vitals are, like respiratory rate and her baseline mentation and stuff. And then after that, I'd like to get a VBG or something to see what the gases are at.
Okay. Gabriella, you successfully handled night float your very first month in Birmingham. What do you have anything to add to what Sandkelp has said?
Yeah, I think that first I would like to know her baseline, if she has any neurological symptoms as a baseline, and then vitals. I think one of the first things that I want to ask, while I'm on the phone with a nurse, would be what the vitals are at this time.
Okay. Um, so, Kiki, you're you well, let's make believe like you're the upper level, and you've been busy and come back, and the intern seems confused, and he or she asks you, "What do you think about this plan?"
Yeah, well, I think, both Sankup and Gabriella made two really good points. As I mentioned in other unremarkable labs, it's really important to get as much information from the nurse when you're on the phone with them before you hang up, and asking the nurse, have you gotten recent vitals? What is the O2 stat? What is the patient's baseline? Tell me exactly what their mental status is right now. And is that a new change from when you had the patient earlier in the day, or I guess in this case, the evening? All those things are really helpful to, as we mentioned before, contextualize the patient and get a sense of one, how sick the patient is, two, how quickly you need to go examine the patient, and three, what might be the etiology of what's going on.
Anne Marie, do you have any other thoughts?
Yeah, I completely agree. I think one helpful thing on night float is have a very low threshold to go and see the patient. This patient sounds really sick. Go and eyeball them, because sometimes you see a patient and they're so sick that they need immediate action. So I definitely agree with getting vital signs, checking the ABCs, and then I have a very low threshold if someone is altered and somnolent and hypoxemic, and I think they might, that might be secondary to opioids, to give Narcan and see if it resolves, and then also get like a loaded ABG and also see if there's hypercarbia or anything else. But I think I'd also just want to make sure I wasn't missing anything. She has COPD. Could she have a pneumothorax? Could there be obstruction there? She has metastatic cancer. Could there be some sort of tamponade or some other etiology? So Narcan is easy to give and you'll see results quickly. And then kind of as I'm doing that, working with a nurse, also thinking about kind of what are my next steps, what other things do I need to be evaluating for?
I'm going to throw one thing out, and it might be obvious, but it might not be obvious. So I'd want to know how much oxygen she's on right now, and whether they've been titrating her oxygen. Have they given her more oxygen than she really needs? What's her O2 sat been? Just because I know she was on 2 liters at home, but what's she on now? And what is her oxygenation now? Because sometimes you get altered mental status because they start hypoventilating. So, Moet, what more do you want to give us?
Sure.
We'll get more information.
Yeah, so as you're talking to the nurse and walking over to see the patient, as you should, she tells you that, oh, I didn't want to call you earlier because I know you guys get so busy on night float, but earlier in the night, she went from her normal 2 liters to 4 liters nasal cannula. I didn't get a chance to call you, and I felt bad to call you about that. But in terms of her mental status, normally she's ANO times 4, she's interactive. But just recently when she went to check on her, she is just a lot more drowsy, hard to arouse, and just has kind of garbled speech. So you get there and you get the vitals with the nurse. She's afebrile. Her blood pressure is 130/70. Her heart rate is 80. Her respiratory rate is 10. She's satting 94% on that 4 liters of nasal cannula. Your exam, she's drowsy but still arousable to you shouting her name and to sternal rub. She does have shallow breath sounds, but equal breath sounds bilaterally and anteriorly. Otherwise, neurologically, she's grossly intact, and cardiopulmonary exam otherwise was unremarkable.
Great. So, Gabriella, what do you think at this point?
Yeah, I think a few things on her. First is that respiratory rate is 10. So given that the oxygen was increased to 4 liters, we're suppressing the respiratory drive. So that's the first one. And then she's on opiates. So you have an Narcan, like the side of the bed would be like my next step for her.
Great. Sandkelp, have you run into this thus far on night float in your first week?
Not yet. Yeah, but like I agree with what Gabriela says. Yeah, I would also like to stop the PCA.
You're fading in and out, so we need to go ahead and start again, Sandkelp.
Can you hear me now?
Now I can hear you.
Yeah, I have not experienced such a case. Yeah, I cannot like I did not see such a case on night float yet. But I agree with what Gabriela said. It's most likely looks like secondary to opioids, and I would stop the PCA going in at least now and get like a stat BG or an ABG to see how's the confusion on AMS.
Okay, so Anne-Marie, you get the first shot at being the upper level.
You're muted, Anne-Marie.
Sorry, it sounds like where we are now, you know, she's somnolent, her respiratory rate is down, so we've stopped the dilated PCA, her oxygen is up. We are, sounds like, going to get an ABG, which I think is appropriate here, because that will allow us to not only see the CO2, but also see the arterial blood gas concentration. And it sounds like I think it would be appropriate to try a dose of Narcan here to see if that improves things. But, you know, as we're doing that, also, you know, listening to both lung fields, making sure there's breath sounds bilaterally, making sure we don't hear any wheezes, anything else, listening to the heart, making sure there's not muffled breath sounds or elevated JDP, just kind of like running the list of other things here to make sure we're not missing anything else.
Kiki?
Yeah, I think one good way to kind of conceptualize this is, what are you going to do in the next few minutes versus what are you going to do in the next maybe 30 minutes to an hour, and kind of how sick the patient is really helps me decide that. So as mentioned, the patient is somnolent with increasing O2 requirements. That's enough to make me act and do as much as I can in the next few minutes. And things that we can do in minutes would be, like we've already said, give Narcan. I think we have to, and maybe for the students who don't know, there are some limitations on the floor. For example, like getting a blood gas within a few minutes is usually not possible, as most floors don't have an iStat machine. And so to get a blood gas, you're going to send it to the lab. That's 20, 30 minutes, even if you place it stat. And so you have to decide, is there something that I can do in the meantime to help manage this patient? And something as quick as Narcan is something that you can do. I know someone mentioned chest x-ray. That's also another thing that will probably take 15 to 20 minutes. One thing I've learned very early on when I was an intern is that whenever I order chest x-ray and I felt like it's going to change my management in the next 30 minutes, then I need to order it stat, number one. And number two, if I order it stat, I need to go ahead or ask someone to go ahead and call radiology to make sure that they got the stat order and that they're coming up right now. Because although stat means quickly, sometimes putting a little extra fire under someone really helps get the necessary people there. I feel as though, kind of back to the ABG point, if you do need answers from an ABG rather quickly, then it's probably best to go ahead and call a MET call. That way the MET or the medical emergency team will come to the bedside, and they always carry an iStat machine and can give you what you need. So yeah.
Alonzo, you helped Mohit with this. Could you reflect on what people are saying? And I actually, there's a question I'm going to raise that is people are going wild in the chat about, but I want to hear your thoughts first, Alonzo.
Yeah, without talking too much about the specifics of the case itself, I think everyone's thinking is going exactly where I would be going. Something I would note earlier, and again, it's not going to change your short-term management, but you know, sometimes I like getting these extra details. The PCAs, you can actually quickly ask the nurse to pull up the data, and it will let you know kind of specifically if this patient is getting a basal amount of Dilaudid through, how often they've pushed, and how many doses they've gotten. Because, you know, not every push is a dose. It does lock out. But you can get all of those data points, which, again, in the immediate phase, it's really about the idea of this trial of Narcan. But in the long-term phase, if they're pushing all the time and getting into this kind of trouble, that means we have too much pain and not enough control, despite the fact that we may be getting into trouble, and it might necessitate a different kind of conversation with the patient. The other thing I thought was kind of interesting, I don't know if you want to get into it now, Dr. Center, but I think Sandkalp said he wanted to get an ABG or a VBG. And I wonder if we want to talk about that at all. Is this a patient where a VBG with a good pleth on an SpO2 is enough, or do you really need the ABG?
So that really leads into the other question that a lot of people are asking about in the chat, and that is, what is the right goal for oxygen saturation in a patient with COPD? And we all know that, well, maybe we all don't know. Well, first of all, just in case everybody doesn't know what Narcan is, it's naloxone. In case you didn't know, because Narcan is a trade name. My understanding is, no matter what is wrong with the patient, you never want to give oxygen to get the O2 sat greater than 96%. You always want to give it when it's less than 88%. Now, trying to figure out where you should be with COPD, I don't know that there is an exact number. I'm not concerned about the 94%. I'm concerned about the respiratory rate, and I'm concerned about the mental status. Now, could the patient use less oxygen? And so Sandkelp said maybe a VBG, maybe an ABG. So I would like to, first of all, Gabrielle, what do you think? And then we'll go back through our three young bucks or does or whatever they are, the three hospitalists, and see what they would say. So Gabrielle, what do you think?
Yeah, first, if I want to evaluate oxygen on this patient, definitely an ABG. But if I want like something quicker, bedside with the meds team, and just take a look to the CO2 for her, I would go with the VVG if I have a previous VVG to compare to.
So the VBG is going to help if all you care about is the PCO2.
Yes.
And you can almost deduce what the PO2 is. So that's interesting. Kiki, what would you do in this situation?
Yeah, so I'm a fan of VBGs. I try not to do ABGs because they're extremely painful for patients. The only time I use it is if I absolutely need the PaO2, an accurate one. Mm-hmm. For me, I really use the waveform of the pulse ox to get a sense of how well is it picking up. If the waveform is poor, or of course the pulse ox is extremely low despite being maxed out on oxygen on the floor, then that's really the case where I try to get an ABG. I get the ABGs myself. Usually Respiratory gets them, but if I need it, I'll just do it myself. For me, a VBG is helpful. My main concern with hypoventilation is that the PCO2 is rising. And so a VBG is perfectly suitable to get that. From what I've read in the past, you guys can correct me if I'm wrong, but kind of the PCO2 is about a difference of 5 from an ABG to VBG, so it's relatively close. And pH, I've read it's about a difference of 0.05, so it's also very close. And so if I can use a VBG, then I'll go ahead and do that.
So somebody wanted to know, Kiki, you look at the waveform, and one of our learners is concerned they don't know anything about the waveform, and how are they going to learn about the waveform, and how does that help you?
Yeah, so I wish I had a picture. I would share my screen. I can try to look up one real quick, but it sort of is, it does this little motion, essentially. Oh, thank you. Look at that. Yeah, can you make that larger?
This is our master of ceremonies, the one, the only.
Yeah, so perfect. So essentially I look for a waveform closest to the one on the top. And that lets in, if the patient's on continuous O2, you can see that, or if they're using a machine, you can usually tap it and get to the actual waveform. So I look at that to see if I'm getting a good, if the machine is picking up a likely accurate accurate O2. I also have a pulse ox that I carry in my pocket that also shows me the waveform, so I don't have to always find the machine, and I like to use that as well. But essentially, if I get that waveform, then I know my O2 sat is probably accurate, and I can go off of that rather than getting the ABG for accurate PaO2.
So just a tip for the medical students and the interns, if you don't have your own little pocket pulse ox attachment, they're not that expensive. And it really saves you without having, without having to figure out where the pulse ox machine is, or how to hook it up, or it's just easier to do it yourself. And so what Kiki said really is really important. I'd like to reemphasize a point that she made, and that or maybe Gabriella made it, but if we knew what the PCO2 was when the patient came in, we had a VBG, we're looking for a change. The other way to get at that is we will get a fairly accurate pH. So if the patient has an elevated PCO2 and significant acidosis, you can assume that it's acute. If they don't have a markedly lower pH, then you can probably assume that that's their chronic state, because it takes a while for the kidney to adapt. So we can use the combination of the PCO2 and the pH from the VBG to make those points. Anne-Marie, do you have anything else to add? We've really obsessed over this, but I think it was worth obsessing over.
Yeah, I think those are great points. Usually if I think someone's sick enough that they're rapiding and there's a team there that can get an ABG, I'll draw it, but I do understand kind of the points about if you have a good waveform and, trust the oxygen saturation and everything, that you could use the VBG for pH, where it's most accurate, and it's fairly accurate for CO2, maybe a little less accurate. So I think either is reasonable here. I don't know that there's a right or wrong answer, but I do think if you're using a VBG, also making sure that you have that good wave and that you trust the oxygen saturation is really important.
Alonzo, you helped make all this up. This case.
I love this discussion you guys just had. And to be completely honest, me and Mohit had a heated discussion about this, a debate. And he taught me a lot of things. I got to tell you, Dr. Sentor, I don't know why, but I was always the guy to very quickly go to the ABG. I didn't trust VBGs. I didn't like VBGs. And I never trusted the SpO2. I looked it up. I read some studies, and honestly, when you have the good waveform, just like Kiki was saying, and you trust the SpO2, and you're talking about an SpO2 and 90% or above, it correlates very nicely with a PaO2 60 or greater, which was something that kind of, maybe I never believed, but I finally I read the data, and I think if I had told you this before I had discussed the cases with Mohit, I would have said, to hell with your VBGs. I want the ABG. I'm going to get it at the bedside. I'm going to have my intern run it down and give me the numbers. But now I've been converted to the church of the VBG. I'm ready to look at the waveform, check out the SpO2, and honestly, just to save the patient the stick. That's really, for me, that's really the big driver here, because it's not from, I did these just left, right, and center in residency. They're very easy to get. They're quick to run down and get done. But really just to spare the patient the pain of the extra stick.
Yeah, the one time that I really like an ABG is when the patient first comes in and there's a dyspnea type complaint and there's a concern about shortness of breath. The FiO2 is room air, but the saturation is like 95%. And but maybe they're hyperventilating. So in that situation, because I can estimate an AA gradient and say I really need to go further down the lung story, but I don't have to do that here. I already know the patient has COPD, so I'm not not trying to prove to myself there's an A gradient. So in that situation, a VBG, I think is really great. So Mohit, ha, tell us what you meant to happen in this case.
Yeah, I mean, I think you guys pretty much hit on everything that meant to happen. So I think it was a really rich discussion about ABG versus VBG. I'm glad Alonzo is now on board with VBGs. I think Travis.
He is trainable.
Travis, I think, linked a blog post about the differences. I'll probably tweet out something about it too, because I think it's worthwhile. So I'll give you guys the VBG and the ABG and let you guys see the difference. So VBG for this patient acutely was 7.2 pH, PCO2 was 80, bicarb was 28. The ABG was 7.24, PCO2 is 72, bicarb 24, PaO2 is 70. And to answer everyone's questions, like the pleth was just fine. We trusted the pulse ox. The chest x-ray had showed bilateral basilar atelectasis, which we thought was secondary just to her hypoventilation. We stopped the dilaudid PCA and administered Narcan. She responded to that well, and we were able to prevent her going to the ICU with that. We just titrated down the oxygen with a goal of 88% and above. Kept just monitoring her overnight. She continued to do better from a respiratory standpoint. We had to kind of spot her doses of Toradol to help her with the pain, which is ketorolac for others. And then we ended up not having to transfer her, and she ended up doing better.
So because this is technically called unremarkable labs, I think the most important thing here is how to interpret either the VBG or the ABG. And they both show you acute respiratory acidosis. And that's the clue. The good thing about the VBG is you get both the pH. You can see the bicarb has not adjusted yet, which means it has to be acute. Mm-hmm. Does that make sense to everybody? And so, yeah, even Alonzo doesn't need this ABG. We can just work on the VBG. Yeah. And this is the type of thing I think everybody who was discussing it had all the right instincts. And so what I hope the learners got out of this is what's the quickest way to proceed. I think that it's really important to listen to what Kiki said about really finding out from the nurse what's going on, getting the nurse to show you how to look at the PCA, learning how to look at the waveform yourself. All these things will help you when you go see the patient. And the entire discussion, I think, was first rate.
Yeah. I think some of the teaching points that Alonzo and I had come up with already came up within the chat about how too much oxygen delivery in COPD can cause hypercarbia through many mechanisms. One of which was discussed was the Haldane effect. Other one is that they have usually no longer using a CO2 as a driver for ventilation and usually are relying on oxygen. So when you fix that, then you don't have as much of a drive and you lead to hypoventilation and apnea. And then someone else mentioned as well the hypoxic vasoconstriction that then shunts to diseased lung in COPD. The other thing I think for med students and learners here that I like to think of when I think of hypoventilation, it's just a good framework to have in mind, is that it can be caused by two main things. One, a ventilatory drive problem where the patient won't do it themselves. That is the case of our patient where the narcotics probably did that to her. Or from a disease of the respiratory system that they can't do it despite them trying to. And that's a setting of like COPD or restrictive lung disease.
Great. Well, that one took 30 minutes. Let's do one more. But I hope this has been good for everybody. And I hope that those of you who are getting ready to do night float sometime in the future have learned a lot from this. A lot of discussion about the doses of naloxone in the chat. it's worth looking at. But let's do the second case.
All right, guys, we have Mr. A. This is a 73-year-old male. He has a past medical history of non-ischemic cardiomyopathy with a left ventricular ejection fraction of 16% on his last echo, COPD with a 2-liter O2 requirement, rheumatoid arthritis and diabetes and dementia. He was admitted today, status post a fall with negative imaging. Basically now awaiting placement is what you're hearing on the sign out. Significant events over the course of his admission day, had a hemoglobin of 7.9 and was ordered 1 unit packed red blood cells. The afternoon, kind of late afternoon before checkout, patient was complaining of dyspnea with productive cough. The morning chest x-ray on admission was unremarkable and SpO2 was stable. So they was prescribed benzonatate with mild improvement in his symptoms. So this is the sign out you get with the patient. You get a night float call from the nurse. Mr. A now says he's short of breath, he's got productive cough, and she knows he has increasing O2 requirements.
Okay, Gabriella, you get to go first this time.
Okay, so yeah, a lot of things going on with this patient. And again, the first move that I do is just ask vitals. Now that I have more information about the patient, and then just go to the bedside to assess him.
Sankelp.
Yeah, I agree with what Gabriela just said. Again, asking the nurse about what the baseline oxygen requirements were and how's the patient mentation currently. Is the patient able to talk or is he awake? So right now I'm mostly concerned about like my differential for a hypoxemic failure here would be like heart failure versus a worsening of her COPD. I would think heart failure worsening because like the patient has recently received a transfusion. Ejection fraction is only 16%. There's a high chance that there might be some volume overload component going around. So again, of course, I'll ask for the basic vitals and the current signs and then go and examine the patient.
Okay, I think you both did a great job. Kiki, any critiques of what they've done thus far? Any further suggestions?
Yeah, I think you guys are on the right track. Getting vitals is always important, like we said, especially up front when you're talking with the nurse and she's, expressing her concerns. This sort of came up in the chat, and I think Sean mentioned it's a good point. I would like to know, when was a patient transfused? Is he currently being transfused? It's one thing we don't always think about, but should, is a transfusion reaction. And this is obviously a patient that would be at higher risk if his EF is already depressed. He could have a variety of different reactions, which we can talk about later. But thank you. Someone already put it in there. Charlie and Taco are kind of the more common ones, particularly Taco for him would be higher. He'd be more at risk for giving his low EF. So
what
those
the
are just some
hell
of the
is
questions.
taco?
Yeah.
I've eaten tacos, but I don't know what taco is.
You're gonna put me on the spot. I always feel like I messed this up. But transfusion associated circulatory overload, I believe, is the correct. Yes. Okay, great. Or essentially, as
I'm
a
sure
patient,
the people from Brazil have never heard that, and I want to make sure that I take care of them.
I don't know, some smart people out there. But essentially, it could be during or after immediately after the transfusion, where a patient has signs of volume overload, pulmonary edema, and it can present similar to what the patient is having right now: shortness of breath, cough, increased oxygen requirements. And so that's something I like to keep on my radar for patients that are being transfused.
Anne Marie.
These are some really good points that have been brought up. I'm sorry about that.
I definitely think
it's my pager. It really confuses people. It's tremendously fun. But I think that here is a case where there could be so many things at play, and there might be more than one thing at play. So I definitely think, talking to the nurse, trying to figure out what's going on, going to see the patient, and vital signs could really change things here. And then I'm kind of running through the list of what could be going on. I'm thinking, he had a fall. What do I know about that fall? What did he injure? Could he have injured like a rib, or did he get rib imaging, or, what was going on with that? Or could he have injured himself in the fall and so had, maybe he needed that unit of blood because he's bleeding somewhere that we don't know and his hemoglobin's down. So, and then we have the heart disease and the ischemic cardiomyopathy. And I'm thinking, is his heart pumping correctly? Could he have flash pulmonary edema? Could something be going related to his heart? And then I'm wondering, he's coughing stuff up. Could he have a pneumonia? What is he coughing up? And then with the COPD as well, could he have some sort of pneumothorax or something else at play? So there's a lot of different things going on. And I think that going and assessing the patient, getting labs, first making sure they're stable, getting labs, getting, a BBG or ABG, kind of considering all the things that we talked about before, getting a repeat CBC. If you have a point of care ultrasound and can look at the lungs and see if you see C lines, look at the IVC and everything like that, that could be helpful. A chest x-ray and everything, and just like really quickly be running through your mind of all the different things that could be going on here.
Okay, that was beautiful. And I want to just reemphasize what Anne-Marie just did. She said, I'm on night float. I get this call. What's the differential? Because that differential will tell me all the things that I need to really pay attention to when I go to the bedside. So she's ready to go to the bedside. She's going to look for volume overload. She's going to see whether or not the patient might have fallen and have a bruised rib and isn't breathing right. To see, is the patient febrile now? Did this all start with a pneumonia? Is that why the patient fell? And by keeping the differential open and not jumping to one thing and trying to think of all the things while you're going to see the patient, you're going to do a better evaluation of the patient. And so that was a great example for students and interns of how you want to learn how to think over time. It's really hard to do when you're a student and intern, but it's amazing how third year students and even brand new hospitalists sort of have this built in because they've seen enough patients. So Alonzo, where are we now?
So I caught a lot of questions from everyone. I'm gonna try to answer all of them as well as I can. Kiki was asking about the timing of the transfusion, when the transfusion happened, what's going on. Nurse says, Doctor, I'm so sorry. It took forever to do the cross typing. I know this unit was ordered in the morning, but we just got it hung up in the late afternoon. But don't worry, to catch up, instead of running it over 4 hours, we ran it over 2 hours. Post-transfusion CBC is pending. In terms of vitals, they get a repeat set of vitals. Temp is 99. BP is 110/77. Pulse is in the 1-teens. Patient is breathing 25 times a minute and saturating 90% now on 6 liters O2. And in terms of a quick examination, he's mildly distressed. He's kind of sitting up in bed. You do note marked JVT to the jaw. He's tachy, but regular, no murmurs. He's got diffuse kind of crackles and wheezes throughout his lung fields, worse at the base. He's got some retractions. Abdomen's normal. Extremities do feel warm and well perfused. And he is alert and oriented at this time. While you're in there, your baller senior, Mohit, pops in there with a point of care ultrasound and shows you what he says are diffuse B lines throughout his all of his lung fields.
Okay, Sandkelp.
So most of the physical signs and the findings that we have are all pointing towards a flash pulmonary edema, which is causing the patient to rapidly be hypoxic. And so I would like to spot those IV Lasix here, which I think should be helping with most of the stuff that's going on. And I feel like we don't need a repeat echo at this point since we already have a cause and we have the treatment for that. So I wouldn't want to investigate further, at least at this point. And even we can obtain an EKG for sure, but again, this clearly looks like it's acute pulmonary edema case which should respond with diuretics. So I'd go ahead and give IV Lasix now.
Yeah, so there's been a debate going on in the chat over whether we should use furosemide, so Lasix is furosemide, or bumetanide. And I just did this talk with my team yesterday on the differences between bumetanide and furosemide. So just for people who haven't thought about it very much, bumetanide is a very short-acting loop diuretic. It's not going to last as long as furosemide. It is much better absorbed if you're giving it orally, but that is totally irrelevant when we're giving it IV. Either one will improve pulmonary edema before they cause diuresis. How many people are aware of that? And who can tell me why that happens?
So they actually have some venodilation effect, if I'm not wrong. And
Right. So
that causes decreased venous return to the heart and that kind of.
Yeah. As soon as you push in the loop diuretic, you get some relief. It's actually pretty magic. People are talking about torsemide. Torsemide is a great long-term solution. It's not going to help us in the short term because there's not an IV. It's probably better for heart failure in the long run because it lasts for about 12 hours as opposed to furosemide, which lasts around 6 to 8 hours, and bumetanide, which lasts around 3 to 4 hours. So I don't think, I wouldn't be excited whether you gave furosemide or bumetanide, but I agree that would be the first thing I would do. And I would do that before I did all those other things. Anne-Marie, did I get that right?
I agree with that. I think in these situations, I go big. I'm not skimpy on the dose.
No. I'd probably get 100 of furosemide and push it in as quickly as I can get it in. But some people here want to give bumetanide, and that's fine with me also. I don't think it makes a difference if you're giving it an IV push.
I'll just add one thing too. When you give it to the patient, it's important to make sure they have a good response. I think sometimes we forget that. We give it and we kind of go about our day, but you really want sort of 1 to 1.5 liters out from that dose to make sure the patient has had a good response and then need to consider redosing. And
right.
The length of time.
So here's another thing. So you get called to see this patient. Are you going to do all this by yourself, or at what point are you going to consider that maybe this patient belongs in intensive care rather than on the floor? And that's one of the things we always have to think about in night float. We have to think about it in the daytime also, but it just seems like this stuff happens at night more often. So Gabriella, how do you decide, I can just handle this myself, or I better call my resident, or maybe I ought to have my resident call the ICU, or call a MIT call or a CAT call, depending upon where you are, an emergency call to evaluate the patient?
Yeah, I think one of the first things would be the oxygen requirement. So if this patient is already on 6 liters nasal cannula, we can move to a mask. But again, if we need to move to other like ventilation or non-invasive measures, we would need escalation of care, definitely. Something else that I also want to add is that I think even though it could all be explained by flush pulmonary edema, given that he just got a transfusion, his EF is 16%. So one thing that I wouldn't want to miss is like a acute coronary syndrome or an arrhythmia. So
I'm clapping for you, Gabriella, because I was hoping you would say that. You made me so happy.
So I got an EKG, place him on telemetry. And if I already have the ultrasound, just take a look to the heart to see that there is like no wall motion abnormalities. But yeah, that's one of my first steps.
Right. So I think it's great to jump to say, hey, this is probably Taco, but let's make sure that there's not an MI going on. that somehow we induced an MI or something was happening. So, Sankalp, any other thoughts on this one?
Yeah, again, I think an EKG would help us like find out if like there's no other underlying cause. And my other reason for like transferring the patient to the ICU will be if the blood pressure starts falling. Like we, especially with the reduced ejection fraction, and also because the patient might end up needing BiPAP later on if her condition and her oxygen sats don't respond to us giving Lasix. Especially like we know that BiPAP has some increased mortality benefit in heart failure patients, and she also has COPD. So again, I'd watch on the saturation and the hemodynamic status, and if anything worsens, I would be quick to call the vet and get that done.
So, Alonzo, you came up with this. What do you want us to get out of it, and has the team done a good job?
Team, of course, did a fantastic job. Clinical course for a patient like this. He was given IV loop diuretics. Fortunately, O2 requirements continued to worsen, was placed on non-invasive positive pressure ventilation, given nitroglycerin for preload reduction, sent to the MICU overnight. Diurese was able to be weaned down and was sent back to the floor the next day. You covered basically everything I wanted to talk about. I was hoping after Anne-Marie had asked for the lung ultrasound, we could talk a little bit about A lines and B lines. I'm someone who's incredibly clumsy. I have a hard time with ultrasound. Anyone and everyone can and should do lung ultrasound. We're getting a little short on time, so maybe we'll save that for later. The other really big point I wanted to make for young trainees out there is that think about things like fluids, think about things like packed red blood cells as a medication or a therapy, just like any other medication or therapy you do. Don't do it reflexively, don't do it without thinking. This patient was asymptomatic with a hemoglobin of 7.9. If you had looked back in his chart, you would have seen that he kind of floats around there. And it would have been very reasonable to recheck the CBC and see if this patient really needed transfusion. But it's so easy in the middle of the night to get a call from a nurse, hemoglobin is this, what do you want us to do? You just transfuse, you don't think about it. So always look and see, are there comorbidities that are going to get you in trouble? Is it folks with a low ejection fraction? If they really need the blood, they need the blood, but talk about spreading out that transfusion as long as you can. And typically on the floor, I think they'll do it out to about 4 hours. Think about chasing it immediately with a diuretic to make sure you're staying ahead of the curve on this. It's a simple point, but I think it's a really important one.
Yeah, I think another thing that that I would have wanted, we didn't have it when I was an intern, but knowing what the admission pro BNP is and whether the patient is on the borderline of being volume overloaded before you even start might be helpful. But I really like the idea of the diuretic. So we're going to go through, and I'm going to get each of the three hospitalists to give us their big take homes from this session, and then I'm going to ask the two interns what they learned. So Anne-Marie, you get to go first.
I thought two big takeaways are kind of in situations like this, good communication with the nursing staff, getting the vital signs, and then going to assess the patient to, ensure you know what's going on. And then if you're concerned about opioid overdose, having a very low threshold to give Narcan would be my two takeaways.
Kiki.
Yeah, I think Anne-Marie said it, have a very low threshold to go examine the patients. If there's anything concerning from the report that you get from the nurse, or even if you just want to lay eyes to make sure the patient passes the eyeball test. Was one of my big takeaways. The other I thought was a cool point to bring out about the loop diuretics and its immediate benefit on pulmonary edema, and of course making sure that the patient has a good response. And Sankalp brought up an excellent point about understanding when the patient may need a higher level of care, depending on what type of oxygen and how much oxygen they're on the floor and their risk of getting worse on the floor.
Right. This is not someone, you can't call it in. There's an old saying in medicine, when in doubt, go to the bedside. And I don't think you can say that too many times. Alonzo, you and your sidekick at WashU, what did you want us to learn, and what do you think were the big points? Do you want to go first? Do you want Mohit to go first?
Mohit, take it away.
Yeah, so I think, I mean, we hit on all the major points that we had chatted about before this, but one thing in our discussion from this last case I wanted to highlight, everyone was really talking about the oxygen requirements, and in the previous case, talking a lot about the gases, but even more important than those in my mind is also just the work of breathing. You know, even if the patient was satting 99% on 4 liters, but they're tachypnic and they're having a really tough time breathing as if they ran a flight of stairs, that's enough for me to be concerned. I don't need the numbers to tell me differently. They're going to tuck her out, and they're going to ultimately probably need better support with non-invasive pressure ventilation or intubation. That's something I learned from the ICUs. That's something I've learned from the pulmonologists, is that forget the numbers, focus on the actual work of breathing.
I want to just expand on one thing that you mentioned, and that is that tachypnea is a clue, but tachypnea does not necessarily mean hyperventilation. You can have hypoventilation with tachypnea. Mm-hmm. And I have seen people who had normal respiratory rates, but were working so hard to breathe, they just had really big tidal volumes, that they were getting into trouble, even though they were not tachypnic. But they were clearly hyperventilating, and you can define hyperventilation by decreased PCO2. So think about that, both the tachypnea, but also I really like the work of breathing thing. Alonzo, you and Mohit did a wonderful job of giving us the right types of cases to focus on.
Thank you. We appreciate that.
Alonzo,
it was a blast. I love working with Mohit.
Did you have any other points, or did we get to most of your points?
You guys covered everything. Only thing I'm going to say, I am now #VBG squad. I'm ride or die with you guys. You have convinced me. I'm there. And then the only other thing I would mention, listen to your nurses when they call you at night. They may not always be able to say exactly what's going on, but when they have the eyeball, right? They do the eyeball test, and if they sound concerned, be concerned. It's much better to overreact, go see a patient, find out nothing's wrong, than to whiff and miss out.
Sam Kelp, you're on night float right now. Has this helped you?
Yeah, this was like a really helpful session. I really loved the discussion about ABGs versus VBGs. I just had like my MICU last month, and we used to get a lot of ABGs, like on most of the patients. And I've had the same, like one of my attendings talked about looking at the waveforms, and if the waveforms are fine, just like titrating the oxygen level using the saturation rather than relying on the PaO2. And that is a point which was again rehashed today. So that was really helpful. The other thing, like we had the COPD patient. I liked how we talked about how the pH changes matter more than the actual baseline CO2 levels, because I actually saw a patient whose PCO2 was 80, who was maintaining fine, who was talking to us properly. So if like there's an active acidic change in the pH, that's when we need to be concerned. So that was like a good learning point for me. And also like in this particular case, I thought of pulmonary edema, and I think this was like a right response, but I should have thought more broadly and maybe also considered more possibilities instead of directly jumping to the conclusion of it being pulmonary. So it was overall a great learning piece for me.
That's why we have these hospitalist experts, because they just have a lot more experience, and there's nothing like experience to help you get better. And Gabriella, you get the last word.
Yeah, so a few things that I learned today: always check the PCA dose that the patient is getting. As a personal experience, when I was in night float, we actually had one patient who was on a lot of PCA, and we were trying to see how much he was getting, because apparently the maximum dose that they can get on the floor is 8, and after that they have to be transferred to a step-down unit. So that's pretty important, especially when we're considering giving Narcan. Few other things, I think one other word that the nurses tend to use, despite being concerned, is that if they don't feel comfortable treating this patient on the regular floor, that also like raised my alarm to start thinking on a step-down unit or an ICU.
Right. So that let me just reinforce that point because I really like that point, Gabriella. Sometimes the reason to transfer the patient to the ICU is for the nursing care, because it doesn't matter how good the nurse on the floor is. If he or she is taking care of 4 patients and one of them is really ill, they can't spend all that time with that one patient, but in the ICU they can. And so sometimes, even though you can take care of the patient on the floor to get the appropriate nursing care, you're being kind to the nurse on the floor and you're being kind to the patient by transferring them to the unit in that situation. Sean, you're the master of ceremonies. Any final words?
I just want to say, I think we're going to try to make VBG squad trend on Twitter. So I think that's a great discussion point, and it's something that I think in turn I ordered a lot of ABGs, and then kind of going through, I ordered less and less. So, and I really do want to echo I don't feel comfortable. If you hear that, you really need to stop and reevaluate what you're doing. Because yeah.
We all owe a hand clap to Vikram, whose idea was for us to include night float in Unremarkable Labs. And even though it seems like it's not always about Unremarkable Labs, there are a lot of labs in here. It's how to interpret the blood gas, how to interpret a VBG. There's looking at the hemoglobin, what to do with the hemoglobin. There's always labs somewhere in there, but even if there weren't, it's so worthwhile to do this. And Vikram, you really stimulated us in a way that we wouldn't have thought of ourselves. So we can't thank you any more than a whole lot. Y'all have a great night. Good work, Sean.